Good morning, everyone. Buenos dias. How is everyone doing? We're really happy to see a nice turnout here. We know there's 7 other amazing panels. There's one with the 3 New York City commissioners. There's a BIPOC Future Leaders one. There's just so many amazing panels, and we're glad you're joining us. I think we're on schedule, actually. We have a minute, so I'm just going to do some... Can't hear you? Oh, wow. Can you hear me now? You know, I think that was the first time anyone has ever told me they can't hear me. So, that's true. There is always a first time for everything. So I'll move this a little closer. So a bit of housekeeping. If you all don't mind silencing your phones or putting it on vibrate, we really appreciate it. We have amazing panelists, amazing participants. We want to be able to hear everyone, hear ideas, share ideas. So if you don't mind doing that now, we appreciate it. Anyone needs to use the services, the bathroom, please feel free to walk out. We're just going to go over a little bit of the format of the panel. Going to provide a little bit of bio on the panelists, and then we're going to have some questions that we're going to talk about, engage with y'all, and then we're going to have about 20 to 30 minutes at the end to hear from you, what questions you have for our panelists, topics you want to discuss, and at any time, if there's something burning or urgent that you want to talk about, just raise your hand. We have Martha and a couple of other folks here. Thomas, did I get it right? Thomas, who from Shinny and DSS, who are helping us along the way. And we're going to give it one more minute because I see a couple of folks streaming in. We have a lot of seats up here in the front. As Martha said, most people don't want to sit in front. We don't bite, so please join us. All right. All right, 10:30 on the dot. So we're going to get started. Again, thank you for joining us. My name is John Rojas. I'm the Chief Special Services Officer at the Department of Social Services, particularly the Human Resources Administration. What does that mean? It's some weird title that they gave me, but what I really get to do is every day work with vulnerable populations, overseeing 6 programs, including Medicaid, home care, HIV, domestic violence, adult protective services, and a couple of other really key services to vulnerable folks. A lot of the work that we do is really engaging people and placing them into permanent housing, including supportive housing. We run a lot of emergency, transitional, and supportive housing. So it's really an honor to be here with these. Say that again?
Louder.
Thank you. It's really an honor to be here with these amazing women to talk about the services that they provide and interchange ideas. The panel is really going to focus on how do we enhance services in supportive housing programs. How do we braid services? You know, supportive housing gives limited dollars for services, but you know, it takes a village. So we have to augment the services that we provide with external services from the community, other internal services that may be provided, Medicaid-funded services. So this panel is really going to focus on that, the ability to really braid services together, augment and enhance services to enhance the stability of the folks who live in supportive housing. I'm going to take a minute. Actually, before we do that, how many direct service providers who are frontline staff, who are case managers, caseworkers, or direct funded staff do we have here? Raise your hand. Excellent. I love seeing that because you're the folks who really work day to day with the folks that we serve, so that's amazing. Do we have any finance folks here, folks who fund these programs? All right, 2 or 3, all right, great. If it wasn't for you, we couldn't have these programs, so that's important to have you in the room. Leadership, managers, supervisors? All right, the rest of you, okay. Nice turnout, all right. Anyone here not from New York City? Near the 5 boroughs? Excellent. Oh, I like that. Different perspectives from different areas. Awesome. All right. It's really my honor to be able to introduce our panelists. And pardon, I need the glasses to read at my age, so I'm going to do that. I'm going to start with Cal Hedigan. She's the Chief Executive Officer at Community Access. Cal has been the CEO of Community Access since 2019. She joined Community Access in 1999 as Director of Policy, Program, and Evaluation. From 2011 to 2019, she worked as Community Access's Deputy CEO, leading many agency initiatives, including those focused on formalizing data analysis and measuring impact to the work and the program development, expanding participant health wellness initiatives, and strengthening the organizational systems to support the mission. Cal began her work in mental health in 1985 at the Richmond Fellowship in the UK, a non-hierarchical model where staff and participants live and work together in community. Inspired by this experience, she led various positions in residential mental health programs in New York City, working in case manager, intake coordinator, supervisor, and director roles. Cal received her undergraduate degree from Brown University and her MSW at Hunter College. Please give a round of applause for Cal.
Thank you.
Next, we have Debbian Fletcher-Blake. Debbian is the president and CEO of VIP Community Services, a 501c3 organization headquartered in the Bronx that offers comprehensive medical, behavioral, health, housing, vocational, and support services to the community. She served as clinician and administrator at multiple New York City healthcare facilities, including FQHCs, federally qualified health centers that specialize in providing care to unhoused people. Debbian also worked in academia, serving as the clinical director of mobile health program and instructor at New York University College of Nursing. Debbian has been active in building culturally competent workforces, tackling healthcare inequities, focusing on strategic strategies to eliminate disparities, and working to ensure community members are active participants in deciding systems of care. Due to her vast experience in quality assurance, physical and behavioral care, Debbian has served as the subject matter expert on numerous clinical and administrative projects, both locally and nationally. Debbian is a board-certified family nurse practitioner licensed in New York State. She holds a master's in nursing from Pace University School of Nursing with an executive leadership certificate in health information technology from the University of Colorado School of Nursing. Debbian brings expertise and efficiency in the coordination of health and social service programs through health information technology. Debbian holds an executive leadership certificate from the UCLA School of Business and Bachelor of Science degrees in nursing and chemistry. Please give a round of applause. Last but certainly not least, we have Jody Rudin. Jody has Rudin, I apologize, Jody Rudin, has over 2 decades of experience in social services sector, working with nonprofits and in government. She is the president and CEO of the Institute for Community Living, a behavioral health organization with 1,500 employees, providing comprehensive housing, healthcare, and recovery services to over 13,000 New Yorkers. Before joining ICL in 2021, Jody was the executive vice president and chief operating officer at Project Renewal, where she led over 1,000 employees, administered a $120 million budget, and oversaw a 15% increase in revenue. Prior to her work at Project Renewal, she was the executive vice president and CEO at the Debbian Health Centers, where she led day-to-day operations for a multi-site health center network with 15 locations across 5 boroughs. Jody also has distinguished 12-year career at the New York City Department of Health Services, shout out to that, culminating in serving as deputy commissioner. Through her collaborative approach, she led the redesign of services for people living on the street, including bringing the safe haven and stabilization bed models to New York City. She received a BA from Emory University and an MPA from NYU Wagner. Please, a round of applause for Jody. Alrighty, so I'm gonna turn over the mic to these amazing women and to talk a little bit about their organizations, about themselves, and about the work that they do. So I'm going to start with Cal.
Thank you. I'm going to see if I'm using the mic correctly. So Community Access is, I've said this a lot this year, we're a 50-year-old organization. And we serve people living with mental health concerns, and we approach the work from a human rights perspective. Our mission is to expand opportunities for people living with mental health concerns to recover from trauma and discrimination through affordable housing, training, advocacy, and other healing-focused services. We are built upon the simple truth that people are experts in their own lives. And I love our mission statement because it's a guide to our work. We are not the people with the answers. The people who come to us for services are the people who know what they need. They know what has hurt them. They know what has helped them. And it's our role really to support them in moving forward with the life goals that they identify. As the keynote this morning mentioned, we're walking people home. And we're trying to rebuild trust that has been broken by years of, we use the word trauma and a lot in the work without understanding the impact that it can have on the human experience and the length of time that it can take to rebuild that. And by calling out discrimination in our mission statement, we're also highlighting that one of the things that happen to people who are diagnosed with a mental health concern is then they live with additional stigma and additional harms that are layered on the underlying condition that they have. And so we position ourselves, and we're a learning organization, and we don't always succeed, but in trying very hard not to recreate those larger harms of the larger mental health system. We have a set of values that underpin our work, beginning with human rights, as I said, self-determination, peer expertise, harm reduction, racial equity, and healing and recovery. Knowing that healing and recovery are possible for each one of us when we have the right kind of supports. Supports that meet us where we are, supports where we're not being told what to do, but we're being asked what we need. And the nuts and bolts, so we have about 1,600 units of affordable housing across New York City. I'm not going to list all of our services, but just highlight a few of them that really speak to our values. In the context of supportive housing, supportive and affordable housing, our preferred model is to mix people living with mental health concerns with affordable housing for families, because it's a critical marker of community integration and what it means to be part of a community where there families and children and people going to school and coming back and relationships developing over time. We have a crisis respite center that's been operating in Manhattan since 2013, which is an alternative to psychiatric hospitalization. It's 99% peer staffed and helps people move through psychiatric crises without being on a locked ward in a hospital. We have a program I love to highlight, which is called Self-Direction, which is a pilot from New York State we've been doing since 2017, where Medicaid recipients actually get to decide how some of those Medicaid dollars can be used and what's going to help them, like flying to another state to their son's graduation to reconnect with families, like figuring out, having access to a dance class, all these things that are outside of what we consider health services. We also have a program called Pet Access, which means that we open up all of our housing and have for the last 20 years to people who want pets, because we understand the healing value of pet ownership and what it means to someone both to have a pet and to be responsible for a pet, and how it can really, again, move people out of their heads and into community in real ways. And I know there was one other program I meant to highlight, and it's coming back to me. Of course, Harry the Heart Peer Advocacy Center, which has been operating since 1995 and has trained thousands of people with lived experience to become a part of the human services workforce in New York City and beyond.
Thank you, Cal. I'm going to turn it over to Debbian.
Thank you. Good morning. Can you hear me in the back? Yes. All right, very good. So I'm Debbian Fletcher-Blake. I'm President and CEO of VIP Community Services. But before I start, I just want to say my tangible magic this morning is having members of my staff here in the audience. So I just want to shadow them and say thank you for being my tangible magic this morning. VIP Community Services, we're a nonprofit. human services and healthcare organization. And like you, Cal, we are 50 years old. April 1st, we celebrated. It wasn't an All Fools Day joke. We did celebrate our 50th anniversary on April 1st. Thank you. So we are, in addition to being a supportive housing provider, we have close to 300 units of supportive housing right now. We're also an affordable housing provider. We operate a federally qualified health center, a FQHC. We are a certified behavioral health clinic, which I'll be talking later about, and how that intersects with or supportive housing. We provide outpatient treatment for people with substance use disorder. We also have an OTP, an opioid treatment program, one of the largest in New York State. And we recently stood up our mobile medication unit. We were the first in the state to do that, providing access to opioid treatments for people with substance use disorder. So we take medications to them, thus providing increased access to care for those services. We also provide vocational services, training people who work with us, people who are enrolled in our services, including in our supportive housing, and also people in the community. We provide services to them as well. We have a harm reduction program where we go out on the streets and work with our community providers, providing harm reduction services to people with substance use disorder. The services in our CCBHCs are quite expansive. We're also providing those services in school-based health, where we provide mental health services to children through our CCBHC. I'll talk more about the CCBHC, the Certified Behavioral Health Clinic, but for now, I will pass it on to Jody and talk more about the people that we serve as we discuss our CCBHC.
Good morning. How am I doing with the people in the back? Okay. All right, keep me in check if I go astray here. So I'll start by saying that the Institute for Community Living, otherwise known as ICL, is 38 years old. We're knocking on the door of 40. I'm going to try not to have an inferiority complex through this discussion, but congratulations to both of you on your milestones. And I want to start by first saying, Cal, the way in which you describe the values that underpin our work really inspired me. I think we all try to lead and deliver services in a way that adhere to these bedrock principles around truly being trauma-informed and truly being person-centered, but you articulated it in a really lovely way that moved me, and I wanted to acknowledge that. And I need to also say, although she will kill me, that I've been a longtime fan of Debbian's, and it's a personal honor for me to be on this stage with you today. And I hope I'm not telling tales out of school or whatever that expression is, to say that when I was at the Department of Homeless Services, the then leadership at VIP came to me and they were candid about the fact that the organization was going through a rough patch and that the board chair was going to be stepping in a leadership role. And this was all many years ago in ancient history. But now you can't walk into a room in rooms like this without hearing VIP mentioned as a provider of note. And it's clearly a testament to your leadership. And you've got this huge group of colleagues here, and the work that you do is incredible. So I wanted to acknowledge that.
Thank you.
I'll say a handful of things about ICL that I think are relevant in terms of how the perspective that I'll bring to the conversation today. My vision is failing me, and I'm trying to see if my colleague Rosita Marinez, our SVP for Housing, is here. I don't think she is, because when I encountered her in the hall, I told her that I was going to invite her up to field questions with me. And she excused herself to go to the restroom, and I haven't seen her since. But if you are here, Rosita, I want to acknowledge that I'm going to be talking about a few of the programs that you've really been innovating around, and I want to acknowledge that. So ICL is a large behavioral health organization, and we support people in living healthy and fulfilling lives through comprehensive housing, healthcare, and recovery services. And on any given night, about 3,800 people sleep under an ICL roof. And we have, so we provide, we like to think, a fairly robust continuum of mental health services that range from crisis and outreach and multidisciplinary teams to clinics, to, of course, housing as a stabilizing force. And I am going to get into a little bit of detail about our housing portfolio, because I think it's important for the purpose of this discussion. So of the 3,800 or so units, about 1,000 are shelter beds. We have six shelters that we contract with the city's Department of Homeless Services to operate. About 1,000 of the units are community residences and CRSROs, where we partner with the State Office of Mental Health, and we also have a very small but mighty system of care for people with intellectual and developmental disabilities, a little bit north of 100 beds across 12 residences throughout the city. But the bulk of the balance of the housing, about 1,800 units, is permanent supportive housing, but largely scatter site units. And so when we think about supplementing services in housing, it's largely in a scatter site model, where we may be funded to visit very high need people, once a month. So I wanted to contextualize that, because we're going to talk a little bit, I think, throughout the morning about how to enhance support in those environments. We did open our first tax credit congregate mixed use project 2 years ago. We've got a healthy pipeline. If there are any developers or other joint venture partners in the room, very interested in those conversations, and for obvious reasons from a mission standpoint, looking to balance out sort of our mix of scatter site versus congregate. But in part because we want to just be great at delivering services to our clients, but also in part because we want scatter site to be a viable model in the city. We've taken this position that imperfect housing is better than no housing, but how can we move towards making it great? And we see multidisciplinary teams as crucial to that. So we focus a lot on multidisciplinary teams. We run 6 IMT teams, 7 ACT teams. We're now pioneering with the Helmsley Charitable Trust on an IMT ACT step-down model, where we're serving 250 people over a 3-year period, and we launched that about a year ago. But we also have programs that operate and that may be a little bit lesser known, that sort of embrace a multidisciplinary spirit. Our On Track program, which is early intervention for people, where we try to get in there immediately following their first episode of psychosis, which is a lot of data and evidence to back that the earlier you intervene, the better outcomes throughout someone's life or across a range of different metrics. We have the CORE program, previously HCBS, community and housing-based services, and we have a cousin of that for children and families. The acronym is CFTSS, Children and Family Treatment Services. And we are about to launch something that I'll talk about a little bit later called Housing Connect, which is going to be a multidisciplinary team that we've sort of created from scratch, building on all of our learnings around doing this. And I'll save that for later. I just wanted to provide a little bit of a teaser. The other thing I'll say from an ICL perspective, we think one of the things that makes us unique is that we try to provide a whole health approach, and we do this throughout all of our programs throughout the city. But we do this in particular at our East New York Health Hub that we opened about 6 years ago, that's really intended to be a one-stop for people in the community. We have a mental health clinic. We have an OASIS licensed substance use clinic. We have CHN, a primary care partner on site, operating an Article 28 federally qualified health center. This is where we house our CCBHC and a number of our other mental health, behavioral health programs. And we've got a pantry stocked with food, the ability to apply for housing on the spot. And the idea is that instead of creating the conditions where somebody has to take 6 different days off of work and lose income, seeing different doctors and specialists throughout the city, they can come to us same day, meet with a bunch of different providers and services and have their care coordinated, and we try to do this in an integrated way. I'm proud that 3 years ago, 5% of the clients receiving services at ICL received more than one service, and now we're at 25%, and we're looking to build on that, so that's exciting. Thank you. The other thing I'll mention in the context of the services that we provide that lead to stability, and we of course embrace a housing first model, right? And there's no wrong doorway, and we want to work to expedite, people into permanent housing and create as many different pathways to do that. We do run 2 short-term transitional programs that we think are incredibly helpful to stabilizing people so that they need less intensive support when they get to permanent housing. One is our medical respite program, which is a partnership with New York City Health and Hospitals. We have 25 beds. We're expanding to 50. We take referrals directly from H&H. People tend to stay for about 3 months, and it's our job to help them transition to permanent housing. And similarly, we're doing one of those short-term transitional models with OMH, this new model, where people similarly stay for about 3 months, and we support them in getting typically to permanent supportive housing. We've got this great 9-bed program out in Coney Island where people come in, and it really is a community of staff and clients eating dinner every night together, breaking bread. When I was at the city's Department of Homeless Services, we grappled a lot with the question of what makes shelter great. And the single biggest correlation to effective, good shelter was size. Not the provider, not how resourced the program was, but size. The smaller, the better. So when this opportunity came to do a 9-bed program, all I could think about was really the opportunity to make it great. So I've been yammering on for quite a bit. I think, John, I turn this back to you, but thank you all for being here.
Thanks to each of you. It really does show the breadth of services that your organizations provide. I want to take a moment to talk a little bit about supportive housing. We're going to talk a little bit about some of the challenges facing, the tenants that come into supportive housing. Just in New York City alone, we have over 30,000 units of supportive housing. I mean, just take a moment to think about that. 30,000 units, most of them, for folks who have different life experiences. So I just want to put that in perspective as we have our conversation today. Most of the referrals that come to these programs come from the Department of Social Services, HRA, Human Resource Administration, or the Department of Homeless Services, as Jody was talking about. So when we at DSS are working with folks and transitioning them on from shelter, usually shelter, not exclusively, or from transitional programs over to supportive housing, there's a lot going on in a person's life. There are biological issues, environmental, societal, but luckily we found a home, we found a program that fits them. But I do want to, lay the groundwork. If each of you could tell me at least 1 or 2 of the top issues facing the tenants that are coming into your programs, that what are they facing and struggling with, so we could have a more comprehensive conversation on how we could provide services to improve and enhance stability. So, Debbian, I'll start with you.
Sure. Thank you, Cal. So This is not news to any of you sitting here who have been working with people in your residential programs, your supportive housing programs, or your shelters. We too operate shelters and now are in the sanctuary business, providing services to folks living in sanctuaries. And, you know, without a doubt, the top issue that we see with people coming into these facilities is trauma. And that's from a healthcare perspective. You know, the trauma that's faced by children in our shelters, the adults who come into our supportive housing, it's beyond what any of us can imagine at times. The other issues are the social issues, right? So social injustice has created what we see in our country. But it's discrimination, it's the inequities. And so a lot of people who are coming in have some healthcare needs. Mental health and substance use disorder are at the top when we think about healthcare needs. And the stigma that is associated with those illnesses, because we don't see them as brain disease, especially substance use disorder, we see those as behavioral, so, you know, stop, you're behaving badly. And those have manifested over time to really impact people's lives. And so they're traumatized by the stigma that are associated with those two illnesses. So I would say those are the top issues that we see in our facilities.
Kel, what would you say is an issue impacting at your organization?
Just in an effort to add new information, I agree with everything that you said. I think sometimes we forget the financial insecurity of all the people who are living in our programs. And that's huge. And it's a daily struggle. And it's a daily source of stress. Particularly when we have more and more people who are coming into programs on public assistance, and I frankly don't even know how they're able to make ends meet for 30 days in every month. So we've set up a system that really keeps people in the day-to-day struggle for survival, even once they have housing. And I didn't mention all of our housing, or 99% of it is actually what we call congregate, right? So it's supportive housing in one building with 50 to 200 units, right? And interpersonal conflict is a thing in the world, right? Not just in supportive housing, it's a thing in my 8-unit building. And so navigating different lifestyles, navigating those human relationships is another huge struggle to try and help people develop skills or be interested in learning about different ways to manage conflict.
Jody.
Thank you. It's going to be hard for me not to repeat what my colleagues have said, but I'll try to put a slightly different spin on it. The first thing, thank you. The first thing that I'll mention is complex trauma. And I don't mean PTSD, right? The people that we serve have often experienced prolonged exposure to multiple traumatic events that are interpersonal and invasive, and that start before pre-verbal development and extend into adolescence and early adulthood, and they have disrupted relationships with family and often end up in the foster care system, often are in situations where adult role models are chronically incarcerated or abusive, and they learn from this as a way of adapting and surviving that fighting or fleeing are sort of the two options in terms of how to navigate their realities and survive. And there's, as we all know, voluminous literature out there about how trauma impacts brain chemistry, either suppresses or elevates, as the case may be, levels of cortisol, which is how somebody manages stress. So trauma changes the way people see things, the way they experience the world. It changes their brain chemistry. And it also, to the extent that there is underlying predisposition towards mood or anxiety or substance use or psychotic disorders, it can help precipitate or accentuate those things. So appreciating that these are this is a little bit of the sort of formulative life experience that people bring to us, has very substantial implications for how we see them and where we meet them in terms of establishing relationships, and trying to be supportive. The other thing I'll say is systemic racism, right? We know that many of the people we serve are born into systems of inequity that hugely impact the quality and opportunities around housing and healthcare and economic success, and the list goes on and on and on. And so not only do they not get to benefit from quality services, but they come to us feeling angry and understandably distrustful and marginalized. So an enormous factor is how to build trust, right? And when I talk to some of the psychiatrists and social workers on our team, sometimes they're treating an illness, right? But one of the greatest illnesses that they're treating is the poverty that comes from just massive and systemic marginalization.
Thank you for that. And I do want to wrap up that question on a high note, on ending on how our services, how supportive housing can be successful. And I was greatly moved, and we were talking about this before our panel started, about Ms. Helen, who was at the plenary session, how she shared her struggles and how she wound up in the park, which at one point was her source of misery, and then wound up at the park again as her source of joy. And that was something that occurred through supportive housing, not just having an apartment, but having a home and having the ability to self-actualize and realize her dreams. So I just want to highlight her because I was so moved by her and her words. And there were so many powerhouse people on that stage, the first deputy mayor, Sheena Wright, and many, many others. But the woman with the softest voice and the calmest tone is the one I think who brought down the room. And her words really resonated. So I just want to take a moment to acknowledge, I don't think she's in the room, but we saw you and we heard you. So I want to acknowledge that. Can we give her a round of applause? And that's a good segue into, the approach and how we approach supportive housing and services that are provided at the agencies that supportive housing reside in. And I think the interdisciplinary nature of the work that we do, it's not cookie cutter, it's not just clinical, it's, she's not a psychiatrist, it's not just the housing, it's the wraparound services. So I wanted to start a conversation on interdisciplinary teams and the vision of that at your organizations and how that works at your organizations and what that's comprised of in order to help the tenants that reside in supportive housing. Whoever wants to get the conversation started. Sure. Jody.
Sure. I'm really excited to talk about our multidisciplinary teams more. So I think, from my perspective, there are a few commonalities across all of our multidisciplinary teams. One is that they all have peers, right? And someone once said to me that peers have fairy dust in their pockets. And that's one of the coolest things I've ever heard. And we try, and I know the CCBHC model, endorses this too. We try to have peers forward-facing as the first experience in working with us for the people that we serve. So they're an integrated part of all of the multidisciplinary teams that we operate. The other thing that I would say is, sometimes we look at the number of clients that we serve who are adherent to, medication regimens and that sort of thing, but really we see the treatment as the relationship with us and an opportunity to connect with people who aren't going to leave, right? Notwithstanding some of the turnover plaguing our sector, I need to be honest about that. So in a very real way, multidisciplinary teams become an opportunity for connection, not just with the one case manager that a client is assigned to, and let's hope that's the right fit, right, and fingers crossed, and it's a little bit of a crapshoot. But this creates an opportunity to connect with a group of people. So if you don't feel like talking to the nurse today, or the conversation with the peer is going to be too difficult, there are many different ways of connecting with us, and there's real client choice that undergirds that. The other thing I would say is that we see multidisciplinary teams as like a microcosm for how somebody might connect with their community more broadly, right? So you can practice, I don't know if anyone's ever in this room been in group therapy, but like in the same way that the group therapy becomes a microcosm for life, and you can sort of experiment with how you show up and who you connect with and how you connect with in a really safe way. That's how we see multidisciplinary teams. So I mentioned the fact that in some of our scatter site funding models, we're funded to visit once a month, sometimes twice a month, and this is in the context of people who may or may not be willing to open their doors. We leverage multidisciplinary teams to make the supports far more robust. And the program that I had teased earlier that we're in the process of launching is called Housing Connect. And it's something that we made up based on our experience doing this. And I think some of you may be familiar with this Medicaid enhancement funding through OMH, where a little bit of a dipping the toe in the water of having Medicaid pay, not for housing itself in this case, but for housing services. And so for certain state OMH funded units, there's an additional, I think it's $1,200 per unit per year. So we're taking that funding and we're building this multidisciplinary team that consists of peers, nurses, social workers, a program director that's a licensed LMSW, occupational therapy, which is a magical tool. Really, like, talk about wrapping up nursing, home health, recreational specialists, and case management into one. And so we have a framework that we use around identifying people who are at the highest risk within our housing programs, and we're looking to provide supplemental services to about 200 of these folks through this program that we're in the process of launching. So really excited about that.
In that same vein, I'm going to ask this to Cal. Why is it time to reimagine staffing patterns in supportive housing programs?
I know this was my question, and you would think I would have an answer. So, in New York City and across New York State, we've been doing this. I've been doing this since 1989. We've learned things in that process, and I don't think we've said, wait, we need to reimagine how we're staffing programs. I think originally people in the context of supportive housing were seen as linkers, right? There was this magical land of community resources out there, and the workers in supportive housing were going to connect the people to those resources and the trajectory of people's lives were going to change. And that happens for many people. But there are people for whom that doesn't work, that they need people, just as Jody just described, who can bring those resources to them. And you know, sometimes I always think of, and maybe I'm wrong, like that housing is the stepchild of the mental health system. That people who are connected to resources in the community, if they stop coming, they get discharged, right? If they don't show up for an appointment more than 3 times, if they can't tolerate a long wait in a waiting room, you know, all these services have a door that too often closes to people. And we need to bring the resources to people in ways that work for them, that work for their lives. And so, and not fight for the funding. I mean, I have a vision that is exactly yours, Jody, about a team like that, but I don't have the money to do it, and it's a desperate need.
That's a good segue to our next question, and I do want to take a moment to highlight. I know there's a lot of direct service staff, caseworkers, case managers here, and I want to give them a shout out because I think that is the one staple that is across all supportive housing, congregate, scattered site, emergency, transitional, et cetera, safe havens. But often we think that the sheroes and heroes at these, that are case managers are going to solve every problem that someone comes in, you know, like that's going to be the solution. You know, we fund you for a caseworker or a case manager or whatever title, because they often get changed. But that's not the case, you know. As we talked about in the last couple of minutes, it takes a team, it takes a village. But to ride on that theme that Cal was talking about, how do you see flexible funding if you had the opportunity to take funding and be a little more flexible? How would that enable you to enhance the services at your housing programs to really be more successful beyond what you guys are now in your success? How do you see that? Debbian, do you want to share?
Sure. So, you know, housing is healthcare, and healthcare is housing. If people are not healthy, it doesn't matter what housing you provide for them, it's not going to last, right? Either they're going to be 6 feet under, or they won't be able to enjoy the housing that you're providing for them. And that has been my mantra for decades of providing services to people who are unhoused or in supportive housing. We've got to make an environment where people can receive the services that they need in addition to the healthcare services. And as Cal said, you know, case managers and staff are working very hard to connect people to the outside, to the community. And a lot of times, and we know this, and Jody touched on it, that institutional racism is everywhere. And if we think it's not there, then we're fooling ourselves. And so trying to get the residents in our supportive housing facilities connected to community care is very difficult. A lot of times the services that they're receiving is second class. They have to wait extended periods for appointments. There are no mental health service appointments for months and months. Physical health, you can't really connect them. And so for what Jody's program that she's standing up, it's an excellent program because what it does, it connects all those services and people don't have to stand online and wait for those services and then be treated as second-class individuals. We don't want the people in our facilities to be treated because they have mental illness or they have substance use disorder as if they are not worthy of the services that they're getting. And so the whole health approach to care is so important. But of course, none of us is funded by any one funder for those services. And for foundations or funders in this room, this is something that we really need to pay attention to, because what it does on the back end is it costs our systems a lot of money. when we don't coordinate care. And so whole health is what we try to do with or CCBHC, or Certified Community Behavioral Health Clinics. And those are separately funded from or supportive housing. The CCBHC started in 2016 by SAMHSA, Substance Abuse and Mental Health Administration, as a demonstration project, and New York State licensed their first 13 in 2017, and VIP became a CCBHC at that time. There are 9 core services in a CCBHC, and the most pertinent to the services in a supportive housing are outpatient mental health and substance use disorder, peer services and crisis management services, and linkage to primary care. All the services are important, but those are crucial, as you guys know who work in the field, that those are critically important for the health and safety of the people who live in or supportive housing. And so we became intentional in 2020, just around COVID, just starting before COVID, and then COVID really took things a different turn. And so by 2021, we were very intentional about how we were going to incorporate our CCBHC services into our supportive housing facilities. And we, in all our facilities, we have interdisciplinary teams. And when I look at the data and I see that the majority of the visits to emergency department were coming from our supportive housing, then we had to pause to say, what can we do differently? And that's when we became intentional about expanding services and making services available to or supportive housing. And so working with bringing in peer support, bringing in mental health services and trainings, not only for the residents but also for the staff, trauma-informed approach to how services are delivered. And Jody talked about the implications of and the impacts of trauma on human beings. And so we did that, and we also make available and accessible crisis management services. And I asked my team, I said, what are some of the impacts since we started doing this? And they recently conducted a survey, and 90% of the people in or supportive housing said having ready access to mental health services when they're in crisis was truly important to them. That's 90%. We started out with 0% of our the residents in our supportive housing linked to care, to mental health and physical health care, and now we have 30% who are linked to or CCBHC services. So providing that whole health, and then the question is, how do you pay for it, right? Because these things are expensive. We also provide medications for people in our supportive housing who don't have sufficient funds to pay for their medications. We pay for those. And so, it's very important. Mental health services, a psychiatrist is very expensive, social workers are expensive, and all the services. So how do we do it? Through our CCBHC, we're able to pay for those services for the clients who come in. But we would not be able to do so if we did not provide those services ourselves, those wraparound. And, in our mission, we say we provide behavioral health, physical health, et cetera, and wraparound services that are equitable. And for equity, it means we meet the people where they are. And so every individual is different. And so we don't provide the same, but we try to provide services that meet the needs of each of the individuals in our supportive housing. And so you're sitting there and you must be wondering, so yeah, right, that's good, but how do we do this? We don't have funds, we're not CCBHCs, we don't have OMH funding coming to do this. And I will say to you, partnerships are important. partnerships are crucial. You can't do this alone, and you shouldn't try to do this alone. They're good partners, and there are challenges to partnering. But, seek out good partnerships where you have a pipeline for your residents to be able to receive the services that they need. And I'll stop here.
Thank you. I want to continue a little bit on that theme about the flexibility of funding and services. I know Jody talked about peers and other wraparound services, and so did Cal. How have you managed to integrate that? I know that, and I've worked for government a long time, and each program has very unique criteria, and sometimes we overlay. I'm looking at Mark, thinking, a continuum of care, how do we overlay? But how has that been successful, even within sometimes the rigidity of services and the requirements of the oversight agencies? How have you managed to be flexible, even within some of that more structured rigidity that sometimes exists, to enhance the services that you provide?
Just to speak for a moment on the peer issue. So at Community Access, we have a long-standing organizational goal of having at least 51% of our staff identify as users of mental health services. And in the 90s, we removed all the educational requirements for, entry-level and other jobs that don't provide, that don't require professional licensure or higher degrees. So we have an open door in terms of trying to ensure that the staff in the existing staffing pattern, that people with lived experience are well represented in our workforce at all levels. I think the other thing related to flexibility, at Community Access, we have funding that is both city funding and OMH funding across our portfolio. And sometimes, because of the workforce issues that we all know about, right, we end up with underspending in our programs, and then cannot deploy that flexibly. This is a different question, but sorry. I mean, it would be so beautiful if we could take real-time advantage of funding underspending to deploy it where it's needed across our portfolio based on the specific needs within the programs. And it's year after year just so dismaying to me to see how many trips can you fund when you could be doing something more substantial if we both had flexibility across our portfolio and just dreaming flexibility from year to year, so that we could build the system that we need.
And I'll just talk a little bit about peers, and then I'll have you jump in, because this is one of my favorite topics to talk about. Nobody understands the situation unless they have lived it. We can read about it and we can say, yes, we understand, but we truly do not understand it until we have experienced it ourselves. And so I have such respect for people with lived experiences. And we employ a lot of people with lived experiences. And, we tend to think of them as not at the level of other staff members, et cetera. In my organization, they are professionals, because we have people with lived experiences who have JDs, people with lived experiences who are RNs. So, we have to start thinking about the impact that people with lived experiences have on other people who are experiencing the same situation, because they've walked in those shoes, and those shoes are not too big. And so by employing and creating an organization where peers and peer navigators are professionals, we're able to use them in different capacity. They play a significant role in our supportive housing, in our shelters, in our substance use programs, in our primary care programs. So they're everywhere we have veteran peers, we have, whatever the lived experience may be, they connect differently. And it's so, so important for us to do that. And sometimes it doesn't really cost us anything in our supportive housing. We can begin to think about who are the stars in our supportive housing and start identifying and sending those stars for training to become peer advocates, so that they can enhance what you're doing. And with our peers, what we're able to do in this environment where workforce is an issue for everybody. Raise your hand if workforce is not an issue for you. Okay, that's what I thought. One person, yeah, I'll speak to you after. Extending our workforce is so critical, and also using our staff at their highest capacity. Right, top of license is what I say. And so by extending our workforce, using peers, using our, instead of having our social workers doing some of the work that peers do better than our social workers, I always say there's work, I'm a family nurse practitioner, there's work that peers do much better than I can ever imagine to do. And I am comfortable in my shoes, knowing that I can't walk in those shoes, and to rely on them to do that, so that I can do the work that I'm trained to do. So that is extending the workforce, an innovative practice. Train, think of the people you have. You have gold stars among you in your supportive housing. Look for them, train them, help them, because they want to do better. All our residents want to do better. So let's empower them.
I'm feeling inspired. Yeah. I'll just add a few quick thoughts on this topic around sort of maximizing flexibility and maximizing funding streams to do this work. So we at ICL start from a place of what are the program models that afford the most flexibility so that we can meet clients where they're at and show up for them in a way that they're telling us would be helpful to them. And so I have to give a plug for intensive mobile treatment, which I think is one of the most person-centered programs out there, right? And part of why that is, well, it's very service-rich, right? You've got a multidisciplinary team of about, I think it's 9 staff serving a group of 27 clients. So you can really see people as frequently as they need or want to be seen, every day, if that's what the person needs. But not only that, you can take them to a baseball game. If they're a Mets fan and they haven't been to a game in 20 years and that's what they yearn for, from my perspective, that's as much health care as going to a doctor's office, right? And so part of the flexibility there comes from the fact that you don't have to bill Medicaid for services, right? For some of our programs, there is an inherent structural rigidity. Oh my goodness, I have to keep this person on the phone for 20 minutes or else we're not going to be able to bill, and my supervisor's going to get angry, and we're going to have a program deficit, and this is like a sort of existential viability question. But there are some programs that are inherently and intrinsically more flexible. So how do we as service providers sort of vote with our feet and demonstrate to government where we think, where we think we'd be set up to help support our clients in the most effective ways. So that would be the first point that I'd make. The second is that I think government does deserve some credit, right? And the state has been doing a lot, actually through the CCBHC model, around trying to create regulatory, relief isn't the right word, but more flexibility, right? Clinic without walls, being able to go into the community, being able to serve people irrespective of their insurance status. So part of this, again, is, finding the program models that you can knit together that are going to work for the people we serve, and a whole bunch of procurements recently from the state around, CTI teams and different multidisciplinary teams that are designed to catch people when they fall through the cracks. I often sort of feel and fear that we're becoming a sector that's defined more by failures than our great mighty successes, right? Where the press focus, and Andy Newman from the New York Times left a few minutes ago, unfortunately, but that focus on people falling through the cracks rather than our amazing effective programs and all of the people that we're effectively supporting. So, part of this is putting pressure on government to become even more flexible and to invest more in programs that help us, prevent people from falling through the cracks. And I'll just make one final point that's more structural. Our ICL is predominantly 99% government funded and state funded the most, then city, then federally funded. And with the state, particularly with the State Office of Mental Health, we enjoy the flexibility of being able to have all of our programs with them on one big contract, so that if we underspend, we can, there are some efficiencies, right? That underspending gets pooled together. Or if you overspend in one program and underspend in another, there's an offset that's not going to lead to an organizational deficit. And so this in itself provides flexibility to fund additional services that live alongside and that are relevant and consistent with the work you're doing in your contracts. We unfortunately, with all due respect to our fearless moderator here, don't enjoy that flexibility on the city side. And I think, that's important, because efficient contracting can yield more resources without additional financial investment from government. So I would ask you respectfully to take that back.
Most definitely, and I think we should actually, for next year, have a panel just on flexibility of funding, because I think that's, I spend a lot of my time talking about funding. And interestingly enough, I have one more question I'm going to ask before we turn it over to participant audience questions. When we hear state and city funding, often the funding that we're getting is actually federal. So we're pass-through dollars. Most people go, the city's not letting me do this, but they're actually federal dollars. And I think a lot of the barriers that have led to this is as supportive housing has evolved, because back in the day we used to have, the original New York agreement, and that was very specific. And HIV, probably one of the pioneers of supportive housing. We had we had an AIDS residence. Everybody knew in that building folks with HIV lived. But then we moved to mixed use housing, and that really was a game changer. It really was a game changer, because you never wanted to stigmatize somebody. Oh, that's the DV building, that's the HIV building, that's the building for folks with mental illness, what have you. But and then we started mixing those buildings with community units. But as you do that, you're mixing funding, and it's tricky, because, apartment A has HIV funding, apartment B has mental health funding, apartment C has domestic violence funding. So how do you do that? How do you mix that without stepping on toes? So, no, I agree. I think, and I don't know if I'll moderate that panel, but or even, but I think I'll be in the audience. Before we jump into participant and attendee questions, I have one question for Debbian and really on CCBHCs. And we use that term, and we use the term ACT teams, mobile crisis teams, ICT teams. These intensive treatment team models. And I think one thing that we often forget is that if you're in supportive housing, that's not excluded out of the tools that you can use, because just because an individual or family, a household is residing in supportive housing, that might be an appropriate referral, and sometimes we don't always think that. Maybe the services we're providing are not as intensive as this family, household, individual may need. But I do want to ask Debbian, to talk a little bit about accessing those services if you're not living in the supportive housing program that your agency may be running. Are they open to outsiders, shall I say, to other organizations, other people in the community, or is it in your agency specific to your residents of supportive housing?
That's a great question. But before I answer it, you know I have to talk about the government stuff, right? Funding, flexible funding. The call to action here is, we all should be interacting with Washington, D.C. I was just in Washington, D.C. last week, meeting with our elected officials and talking to them about some of the issues that we're facing here in New York. And whether it's their staffers or it's them, the call to action for each of us in here is to know who to call and to call, or to get to Washington, D.C. and to meet with them, because they need to hear from us, because as they trickle funds down to state and city, they need to understand what happens on the ground in New York City, in New York State, and wherever the other folks were who said they were not from New York City. So that's the call to action. Okay, now to the question. CCBHCs offer services to folks in the community, so it's not specific to or supportive housing. It's for anyone in the community, and actually, I see a CCBHC very similar to a federally qualified health center. Raise your hands if you're familiar with a federally qualified health center. Not enough people. Work to be done. Okay, so a federally qualified health center and a CCBHC are very similar. The federally qualified health center is primary care and some substance use and mental illness, mental health services are provided in a federally qualified health center. It's called federally qualified because the federal government funds it and authorizes those clinics. And so we have to see everyone regardless of their ability to pay for services, and that's a guarantee. And then there are provisions for medications, et cetera, so that we can provide a full complement of services on the primary care side. For decades, we fought for a similar type of health care provision for people with mental illness and substance use disorder. And so the CCBHC is authorized by SAMHSA, Substance Abuse and Mental Health Administration, which is a federal program. They authorize the program, and then the program is administered through the state. Because it's a federal program, it has to be open to communities. And so anyone with a CCBHC, providers like us with CCBHCs, have to provide services for the entire community. We can choose, however, that in addition to the entire community, we provide specific services in CCBHC services in or supportive housing or in schools or in carceral systems or wherever we provide them, but it's open to the community. So another call to action is to learn about CCBHCs, learn where they are, and begin to develop those partnerships so that you have a clear pathway for your patients to receive the mental health services, the crisis services that they need. Another call to action, very much associated but not directly with the CCBHC, is 988. Ensure that your staff and your residents are trained in 988. We are advocating to change some of the kinks with 988. As I said, I was just in DC, and one of advocating to our elected officials that 988, when people call, it should not be linked to as a area code. So if I am in New York and I call, it's going to be routed to where I live in the suburbs. It should not. It should not be linked. It should be linked to the closest crisis center. So again, another innovative practice. Please train your staff about 988. I saw lots of administrators in here. For people on the ground, learn about 988, become proficient, and also train the residents in your facilities. It's much better to call 988 when people are experiencing a crisis than 911, because we know what happens with 911, and we know a lot of poor populations are traumatized and will not call 911 because we know what may happen when we call 911 when you look like me. So please train your folks and CCBHCs, learn about them, they're open to the public.
We have about 20 minutes here, so I want to open it up to questions from y'all, to have questions for our panelists or me. We have folks, Martha, sorry, I'm calling you Martha. Chavez and Liz, who have microphones to help, so we can hear you.
Okay, thanks. Okay. Hello. I just want to say hi, Jody. I worked with you a long time ago when I was at Urban Pathways.
It's great to see you.
Okay. Okay, so, okay, thank you. So what I want to ask about it, I know we're talking about services, we're talking about funding, about enhancing stability. When you're in these mixed-use buildings, there are other people living there as well. Do you have like a best practice in how you engage with the property management staff at these buildings? I know it's a little off, but I'm just curious, because that's something that I look into.
I don't know if we have a best practice, but at Community Access in our congregate supportive and affordable housing programs, we are both the property manager and the social service provider, and we try and have very distinct roles, right, so that service staff are not seen as being agents of the landlord, and property management staff, have a lane, and service staff have a lane. And at the same time, there needs to be so much collaboration and support. And I think in the last few years, we've made real strides in creating more of a team, even with those distinct roles, rather than everyone pointing their fingers at someone to solve a problem. Mm-hmm. So we've been really trying to build collaboration internally.
Yeah, I will just add, and I have my team there, I'll ask Dana to jump in and speak to it. The roles are critical, clear defined roles. And Dana, anything you want to add?
Hi, one of the things that's really important, and it was an excellent question, is to have that relationship with the property manager. When we have our misuse buildings, having that relationship, yes, social services will say certain things, but you're gonna have to have property manager on the same level. Property management mindset is basically like, I need my rent, someone's destroying property, what's gonna happen, maybe this person needs to be evicted. They have to come from a different standpoint, but we need, as social service providers, to let them know, we understand that, and we will help, but we will support our tenants. And that is one of the main things that we need to do. Support our tenants, educate them, because they also need to know, and I love the fact you said about that transitional piece of housing, because it prepares them for independent housing. Property management, we got, pay the bills, take care of the things. We support them. Provide them also with training. Provide them with education, and come to that clear point of, we all want the same thing. We want a safe environment. We want a safe environment, happy, healthy, beautiful building. How are we going to work together? And to support that. And there's a lot of education, but get them on the same page and they will work it out. Okay?
Thank you, Dana. My team knows when they show up, I shout them out.
Hi. Sorry, can you hear me? Thank you. Great. Thank you guys so much for the panel. It's been really wonderful. My question is about direct service providers. I'm actually a service coordinator with Community Access. I started very recently. And one thing that's come up a bit in this panel is staff turnover, especially on that front line. And so, one of my questions was, what are your organizations doing kind of creatively to retain staff? Because I think for service coordinators, you really have to bring your best self to be able to help people with trauma, but compassion fatigue and burnout are big things. And so what are your organizations doing to help support staff?
I'll just start with two things, and hopefully this won't be news to you. So at Community Access, we have a wellness fund for all staff who are earning $70,000 or less, where each year they have access to $500, which I know isn't much, but it's better than absolutely nothing, to engage in services that they self-identify as helping with their personal wellness. We have also tried very hard to have a direct service worker support group within Community Access, and people have asked for that, but then when you do it, they don't always come. So I'm actually thinking about hoping to work with the Supportive Housing Network, that maybe we could have a network-wide direct service support group, so that people from across the sector could access that kind of mutual support. I also think that creating career paths for people is important. At Community Access, we have service coordinators, then we have senior service coordinators, we have harm reduction specialists, we have a huge commitment to hiring from within and internally promoting people. But I think across the board, what we need is, how do we actually value people who stay in direct service work, right? How can we pay people over time, more than a year, more than 3 years, who are committed not to moving up into supervisory positions, but who have learned, like through the hard work that they've done, about engagement in direct service, and so they can be incentivized to stay there.
I'll jump in. Cal, you said a lot, and it sounds like you guys are doing some really wonderful things. From my perspective, we try to live the whole health value that we bring to our clients, to our workforce, right? So that people feel like we're investing in their whole health. One example of this is we do a whole bunch of wellness fairs throughout the year. We're launching now this fiscal year 2 mental health days for everyone. No questions asked, no heads up. Tell your supervisor you're not coming in, and you're not coming in. So that's a new thing that we're doing. In our last strategic planning process, we took a look at our organizational values and sort of made some changes. But one of our new organizational values is growth and mastery, and that's really about investing in the growth and mastery and professional development of people who work at ICL, and that looks a lot of different ways and can take a lot of different sort of shapes, from a robust training program to conferences to leadership academy, and the list goes on. I think the other thing I'd say, in addition to compensation, which, we're constantly trying to get creative about, squeezing more of the dollars out of government and our other funders, is that, and trying to kind of be on the boards of a lot of these member organizations so that we can influence directly through advocating for COLAs and other things. For me, the biggest thing is organizational culture, and trying to nurture a culture where people feel appreciated, not only for the work that they do, but also feel appreciated and seen for who they are. And so constantly trying to kind of push forward on that front.
You both are doing some excellent things. Great, congrats. I'm going to add 2 things is growth and professional development. Can't speak too highly of that. A lot of training so that people have the skills necessary, and giving people tools that they can use even if they decide to leave your organization. You have to do that for professional development. And the other thing, one best practice that we use is everyone in our organization, when you join, you opt into a retirement plan, and you have to opt out. So, most places you have to sign up for it. In my organization, you have to opt out. And so every year, whatever little savings we have, it goes directly into people's retirement. And so the goal there is equity, because we want everyone to participate equally in the program. And so if, last year we were able to deposit 9% into people's retirement. And so everyone got it because we signed you up unless you opted out that you didn't want us to sign you up. And, we start people, I believe it's at 2%. I'm not sure if it's 2% that we pull you in or 3% of your salary, which, most people don't even recognize that we're doing that. But we tell them that you have an option to opt out, and most people stay in anyway.
I wanted to add that ICL also does automatic enrollment into our retirement account, and we are hiring. Please feel free to see me after the session.
As do we. As do we.
We have another question here.
Hey, can everyone hear me? We good? Okay. So my question, I guess, is more for people working in the congregate model. I'm coming from an outreach background, so curious how decisions are made on you guys' end about which services are going to be offered like in the building on site and which services are going to be linkages, and if that decision is like funding based or values based. Are we trying to get people out into the community for services, or is the goal to really provide those services on site?
I'll start and then. I think it is largely funding based, and from our perspective at Community Access, the ultimate goal is for anyone who's able to access services in the community, and those services are accessible and welcoming to them, to make those linkages, but understanding that there's always going to be a segment of people who we need to bring services in. And so the struggle, as I'm sure you've heard, is how do we fund that when it's needed? When I started in the mid-90s, I had the luxury of having 4 hours of a psychiatrist in my small supportive housing program, and no office for her, but she sat in the laundry room for 4 hours a week, and she was able to connect with people who had never ever thought that they had a mental health concern and were not interested in going to a clinic in the community, and she was able to help people, achieve a certain amount of well-being that would not have been accessible if she hadn't been in the building.
I wanted to add just really quickly on this question, because I think it's a great one. From an ICL perspective, we're whole health, so we're going to maximize every dollar towards creating as robust services on site as we can, but also alongside that, holding the value of client choice, right? And some people feel really strongly about not having their psychiatrist be where they live. So creating as many doors as possible for people to walk through in terms of connecting with services in a way that feels comfortable to them.
We're going to take 2 more questions. We have 2 folks lined up, so ma'am.
Hi.
Hello.
I'm Dr. Natalie Richardson. I'm from VIP Community Services, and I oversee housing, shelter, and facilities, and probably service about 3,000 individuals, across the supportive housing, shelters, and those programs. So I really want to thank the entire panel. I have long-term experience with Jody. I'm there with Debbian. We worked together before, and of course, Cal, I know you. I wanted to talk I had a comment around the flexible spending, the budgets, because now when you go to create a budget, which I'm sure all of you know, the city says, this is the model budget, right? And anytime you put anything in there outside of the model budget, they don't fund it. They keep going back and forth. OMB said, and they crunch you into this corner where you have to accept just what it is. So I think that more needs to be done. How do you have agencies with 50 years of experience, 50 years of experience, 38 years of experience, and you're dictating the model of what should happen with the clients that they are servicing? Right? When do you get to the point where you say this is the allocation, as long as you follow the regulatory guidelines, do what you need to do to meet the guidelines, right? And then also the situation around the administrative overhead, right? That you got some making this administrative overhead, some making that administrative overhead. So when there's an agency that's at a lower administrative overhead, they easily have to accept whatever it is because they have to support that infrastructure. You know, when do you get to a point that you say, for these services, everybody's going to get 28% across the board so that they can know what they have and build on that budget? And just one final thing on the budget is around accruals, right? You know, there's this, you know, don't use PS, but as hard as it is to hire staff, if you have accruals in PS, why wouldn't you be able to move that around rather than send those dollars back, right? And then my other comment is around the clients. Clients come to us with low self-esteem, especially when clients wind up in shelter. They could have had a good life. They lost their job or whatever, something traumatic happens to them, right? They come with low self-esteem, like I'm not a good enough daughter, mother, whatever, because they're in the shelter system. We get clients in the shelter system that aged out of foster care, right? They pull them from their parents, put them in foster care, and when they hit shelter, they don't even have a trade or a high school diploma, right? So I think when I look from, I'm an advocate for the homeless. When I look from the client side, some of the things that we have learned, which some we knew and some we didn't, right, is that clients are experiencing trauma at different levels. I think that I most certainly agree with the training for staff, because there are a lot of staff, especially, you know, if they're not right in social service, if they're in maintenance or some other department. So trauma-informed care needs to be across the entire agency so that we don't re-traumatize the people that we are trying to help, right? And then structured socialization and recreation. There was a time that these types of art therapy and things were funded, right? Because how do you take a client, right, and say, I'm going to change your behavior, right? I don't want you using drugs, adhere to your medication, but you have to remember they had behaviors before they came to us, right? So how do you replace that with something that is of a more positive nature, right, if you don't fund structured socialization and recreation? Because they need something else to do. If you look at the stages of change model, right, what are you filling that with? A person that used to smoke cigarettes, right? They come off of cigarettes, right? But what are they gonna do at that time that they always spent smoking cigarettes, right? Or whatever behavior that might be. But we need to introduce those new things to the population. And I'm gonna end with this, that, you know, we move our clients from shelter to supportive housing to the payroll. That's where they go, from shelter to supportive housing to working in one of our programs. They become a staff member. I want to thank the entire panel for all the work that you do and continue to do. Thank you.
Thank you.
Hi, everyone. I'm wondering what opportunities are you thinking about with the state's 1115 waiver and the health-related social needs as it pertains to this topic?
That's a great question. I was waiting to hear that one. We have collaborated with another organization and several others in the Bronx to apply to be a social care network provider. I think there are tremendous opportunities for all of us in this room. And again, it's a call to action. You need to be at the table. You need to demand and keep asking for. And Natalie's right. I ask, if I'm the only voice, then it's not a voice. But collectively, we are so strong, and we really have to ask for what we need, ask for funding that we need, because when I ask, I hear you're the only one who's complaining about that. Now, is that true? I believe what people say, but I'm skeptical. I don't think so, but we have to find a way to unify our voices so that we're all asking for the same thing. We have to walk to City Hall. We have to let our feet take us where we need to go. And in the social care network, I think that's another opportunity where supportive housing providers need to stand up and say, we are an important part of this. Supportive housing is going to be critical. Any type of housing is going to be critical in the social care network. So keep that in the back of your mind. Those are opportunities for you. And so how do you develop the infrastructure that you need, the technology infrastructure that you need to be able to participate fully in these social care networks? Start thinking about that now. What role am I going to play in this? Because there is a role for each of you in this room, I guarantee you that.
And with that,
As he comes up, I'll just say that ICL anticipates being able to participate through the SCNs in a couple of different lines of business: assessment, case management, and housing supports.
All right, thank you for giving me a minute. I like the models across the board, especially when Carl said taking the services to the tenants where they live. I think I would like to implement that type of model, but I realize that everything else is being mentioned and then we get stuck on the founding. And as you guys talk, I began to think of something. When the D-Train was being constructed, I don't know where it starts from, I know it ends at Coney Island. It was not meant to pick people from Coney Island only, but along the road, everybody gets off and on. So we're talking about founding here. I have most of my housing in Crown Heights. What if we, the agencies who house tenants at Crown Heights, come together and say, hey, let's establish or let's create an office in this building to serve all the tenants who live around there. In that way, we draw funding from all the agencies, and if there's a shortfall, my good friend, they will talk to the mayor. Say, hey,
Definitely.
They are trying to do something, but they only have $5. They need 10. Okay, so that these establishments or these clinics that we establish is not only meant to serve hardshare where I come from, or any other agency access, whatever the name is. And however, it's there to serve any of our tenants who live around that area so that they don't have to travel to the offices. We have the same issue. But then I realized that your approach, whereby these services are provided in the neighborhood, is something that will work. So please, I think when we come together as various agencies and get the fundings together, it might serve a purpose. You said, don't go it alone. I heard that. And what about if we come together as a team so that we begin to construct the train that goes to Coney Island by picking everybody along the road?
Yeah.
Thank you.
And I want to thank you for that. I think that's a great way to finish, because at the end of the day, it's about community, and I think we really talked about that. I really want to thank our participants who are with us and our esteemed panel for being here. Thank you.